It's 6:30 and I think we are already a lot of people in the call. I would suggest we start because I will just give an introduction, and if people keep coming into the call, it's not an issue. So thank you very much for connecting. It's really a pleasure to see so many of you tonight. Welcome to the Geneva Macrolabs online talk, COVID-19 tests, where do we stand? And I will share my screen now just to give a short introduction. Voilà. Can you all see my screen?
Yes.
Okay, perfect. So if you would like to mute yourself, if you are not presenting, then I think it would be best for the audience. So I am Renate Günther, and I have the pleasure to be the Vice President and the co-founder of the Geneva Macrolabs, the organizer of this online talk together, And we co-founded this do tank, which call ourselves a do tank, together with our President Eckhart, and I will be moderating the call today. Normally, as most of you know, we meet in person for our after-work events, but due to the pandemic, we had to find new ways, and thanks so much for adapting so quickly. This webinar will be recorded, and the results will be part of the paper that we will publish afterwards, and I hope that's all fine for you. A quick introduction what the Geneva Macrolabs do for those who don't know us yet. We are a do tank that scales the Lake Geneva's area's intellectual potential and brings leading minds together because we want to support the sustainable development goals out of Switzerland. So let's have a look what's on the agenda today. We will start with a presentation from a medical practitioner, Dr. Meier-Heinrich. Anne is an internist, and she will give us some general insights into the COVID-19 situation. And then we will have a presentation about antibody tests, where do we stand. I have the pleasure that my friend Dr. Djin-Ye Oh from the German Robert-Koch-Institute will be doing that presentation. And of course, we will have question and answers and an open discussion afterwards. You're welcome to already indicate your questions in the chat tool. My colleague Jan will be looking at this chat tool and already maybe answering some of the questions during the presentations, but some will be answered at a later stage when we do the Q&A. And so we have two ways to manage the questions. You can either write your question into the chat tool or speak out in the panel at the later stage. So it's up to you how you want to proceed. I'm delighted to introduce our first speaker today. It's, as I mentioned, Dr. Anne Meier-Heinrich. Anne studied in Germany and in the US. She's an internist in Germany, and she lives in Saarbrücken. And it's an interesting place because that's a town that's near to the French region Grand Est in the center, which is practically the center of the corona outbreak in France. So I think she's a very good person to talk to regarding the current situation of a medical practitioner these days. Anne, you have the floor.
Could you close your screen, please?
I'm happy to do that, yeah.
So I can share my screen. Can everybody see it? No?
Not yet.
Okay, just a second. Okay, there we go. Okay. I would like to give you a clinical approach to coronavirus with my everyday work, anything I'm seeing right now, and we'll try to give you an insight of the clinical handling of the virus or of the disease, and also we'll try to cut a little bit through the panic that is around the world right now. Coronavirus emerged as a new virus causing severe lung disease with respiratory failure in China. As of today, we passed 2 million cases worldwide and have around 130,000 known deaths. As the number of cases as well as the number of deaths is probably not mirroring the reality, because we have a high number of cases that are not known, also a high number of deaths that weren't registered. Like you might have read in the news that the death number in UK was only the hospital deaths, not those people that died outside of the hospital. And if we see the number of cases climbing and the number of deaths rising, the world went into lockdown. On a personal level, each one of us is experiencing the risk of COVID-19, the disease, and he is experiencing it as a vital threat. When we see bodies being loaded into trucks and see overwhelmed hospital floors, we simply get afraid and get into panic. The media gives us new counts of cases and deaths every day, and information upon information is coming to us, often differing in content. So we are reacting as we are always reacting. When we are afraid, we are going into flight or fight mode, depending on our personality. That is the reason why we see different reactions, like negating that there is a threat, like some countries did it. On the other hand, overreactions like neighbors reporting everybody that is outside of the house on the street to the police. So important is that this subconscious threat we can't counteract by rationality. We have to accept it and try to counteract it, to live with this fear. And there is where I'm trying to give you a little hope. While COVID-2, the virus, is a risk to all of us, the chances to survive are very good. They are 98% unless you're 85 or older. The highest number of deaths we are seeing is in the age group over 85. The mortality rate there is 10 to 27%. In the age group 65 to 84, it's 3 to 11%. Overall, in different countries is around 2% worldwide. Higher death rates in several countries, like we have seen in Spain, Italy, and France, are most likely due to external circumstances, not due to a more dangerous virus. Like in Spain and Italy, where the health system was overwhelmed and we didn't have enough ICU beds, intensive care unit beds anymore. But what I'm seeing in my everyday work is that most cases are clinically mild cases. 20 to 30% of patients do not notice the disease. They don't have any symptoms, but they might get tested positive, like when health workers are screened, or old age nurses are screened. Death rate rises mainly in relation to the age, also, of course, in the relation to the risk factors, where especially severe prior lung disease is a high risk factor. But even if you get a severe case, which happens in about 5% of all diseases, this can be treated by intensive care, by respirators, ventilation, oxygen, and in extreme cases, ECMO. That is a special technique like a dialysis, where we oxygenate the blood outside of the body of the patient. So we can save a lot of patients, even those that get severe disease, but 95% of those patients that get the disease have a mild version. I don't want to make, I'm not a virologist, but SARS-CoV-2, the virus, is a tricky little fellow, and that's why we are having so much problem with it, because it can be transmitted via droplets and contaminated surfaces. Droplets are expelled if you cough or sneeze, or if you go next to a patient and have a salvia contact. Protection with masks and gloves is working, we know that. Gloves, because the survival on surfaces is, with this virus, is up to 22 hours on paper, 48 hours on steel surfaces, and up to 72 hours on plastics and glass. This is the risk, especially like when you go shopping and are using the touchpad to pay your bill in the shop or in the store, and that touchpad might be contaminated. So in some cases, it makes sense to wear gloves, or if you don't want to wear gloves, disinfect your hands, because washing isn't possible in stores.
Can you mute yourself if you're not speaking? Because you can hear a lot of background noise.
Okay.
Thank you.
Another risk is that healthy persons, that is persons that don't have any symptoms but carry the virus, can shed the virus. That's why we have a high infection rate and why the virus exploded. The virus has an outer fatty layer, making it susceptible to soap, alkaloids, and is easily destroyed by alcohol. So we don't have a problem as far as destroying the virus. We also know that high temperatures and sun destroy the virus. It doesn't look like the virus is going away, so we are going to have to live with it. Restrictions in our daily life will be in place until we have a vaccination or until the virus vanishes. So what we have to develop in the next months is widespread testing. Djin-Ye will tell more about the different methods of testing. Rapid antibody tests, she will also tell you what kinds there are. We have to identify immune persons. We have to, by now and till the virus is under control, protect ourselves by masks, physical barriers, like you see those glass shields or plastic shields in a lot of stores, and gloves, but those protections are effective. Mm-hmm. In the future, we have to use rooms where there are a lot of people with protection or stay out of them. We know from cruise ships, for example, that in closed quarters, or now healthcare homes, that in closed quarters there is a high risk of infection. So what we won't be able to avoid in the future is keeping our distance. In most countries, it's 1.5 to 2 meters distance. Okay. I'm gonna turn over to Djin-Ye, and I listed a number of frequent asked questions that will be published, where I try to give answers to the questions the patients ask me right now. What the most questions we have right now is, there is a new blood test. Can I be tested? Is it safe? Djin-Ye will tell more about it. So while I turn back to Renate and over to Djin-Ye, you can enjoy my questions, my answers to those questions in French.
Thank you very, very much, Anna, for all these details. So if you have questions, you can either put them into the chat tool now, or you can keep them when we do the question and answers after the next presentation. So now I'm happy to announce our next speaker. It's Dr. Djin-Ye Oh. Djin-Ye is a physician scientist trained in virology, my word, virology, and infectious diseases in Germany and in the US. And she recently returned from New York, where she worked at the Rockefeller University and other hospitals. And now she's back in Berlin, working at the Robert-Koch-Institute, researching on corona tests. I'm looking forward to your presentation now. Djin-Ye, you have the floor.
Okay. Sorry.
Very good.
Okay. Is that right? Do you see my screen?
Yes.
Okay,
Yes.
good. Yeah, so as Renate said, I'm going to talk about COVID-19 antibody tests, but just to start with an introduction, where are we now? As you all know, SARS coronavirus is a new virus. The vast majority of people are not immune to it. So that means that without appropriate countermeasures, this virus would spread rapidly through the entire population. The basic reproduction number of this virus, R naught, is 2 to 3. That means that one infected person can infect 2 to 3 others. And in this diagram, this red curve demonstrates what happens if this virus spreads without countermeasures. The case numbers would increase exponentially, resulting in an extreme overwhelming of the healthcare system's capacity, where medical providers, protective equipment, hospital beds, and ventilators would fall short. Social distancing or other countermeasures serve to decrease the R naught, and this results in a flattening of the curve. Whether the curve is flat enough to always stay below this gray ceiling depends on how early social distancing is introduced. And basically this green curve shows social distancing that was introduced a little bit late. So there is an overwhelming of the healthcare system's maximum capacity, whereas the blue curve shows what would happen if social distancing is introduced early enough. In that case, case numbers will always stay below this upper limit. So we all hope that Switzerland and Germany are the blue curve and not the green curve. And once there are few enough new infections, and ideally the R naught is negative, so cases start to decrease, it is considered safe to carefully start loosening those restrictions and reopen the country in a stepwise fashion. Why do we say carefully? Because reopening can lead to a resurgence of infections and to a loss of practically all that was gained during the period of the close down. So some people don't like the shutdowns. They would like to reopen the country just as soon.
Could you mute yourself? Could you mute? You're making noise.
Okay. Yeah.
Please go on, Djin-Ye.
Yeah. So some people feel that they would like the country to reopen as quickly as possible. They would like to finally go back to normal. And one argument that comes up in this context frequently is the herd immunity argument. So herd immunity is a concept that says that when for SARS coronavirus with its R naught of 2 to 3, once 50 to 70% of the population has become immune, the population is protected because the virus cannot spread efficiently anymore. So we just let the virus spread once 50 to 70% have caught it, everybody, all 100% are protected. That is the argument. And herd immunity is normally, that's a known concept, and this is normally generated through vaccination, meaning in a controlled and low risk fashion. Actually, herd immunity will not work for SARS coronavirus because letting the virus spread without obstacles would lead to too many deaths. It would lead also to an overwhelmed healthcare system. And just to get a better idea of why we can confidently say so, we can just do the math for Switzerland. So Switzerland has 8.5 million citizens. Let's say we want 60% to be infected so that we have herd immunity. So 60% are 5 million people that need to be infected. We know that around 20% of those, 1 million people would become severely ill so that they would need to be hospitalized. Another 5% of the 5 million would become critically ill. They would have to be admitted to an intensive care unit, in short, ICU. So you would need 250,000 beds in an intensive care unit, or 250,000 beds for patients who need a ventilator. Switzerland has ramped up their ICU capacity. They now have 1,200 beds with a ventilator. If you divide those 250,000 patients over those 1,200 beds, you have 200 AIDS patients that would occupy one ICU bed. If it takes us, say, a year to let everybody be infected, each of these 208 patients would stay would only have about 2 days that they could stay in those beds. So Switzerland's healthcare system would be very overwhelmed. The current case, a very optimistic case fatality rate that is unrealistic in this sort of scenario is 0.5% of infected people die. So that would correspond to 25,000 deaths within, say, 1 or 2 years that are extra on a normal death. The second contra against herd immunity is that we really do not know enough about immunity against SARS coronavirus 2. The immune protection may actually not last long, and in order to remain protected, people may have to be reinfected the way that people currently need to be revaccinated against certain other pathogens. So in short, the herd immunity concept does not currently work for SARS coronavirus 2. So the question is, what will be next for us? We're currently in phase 1 of the pandemic control, where we are slowing the spread, where we're decreasing the number of active infections. For phase 2, we basically have 3 technical choices. One is letting the virus spread, which is, as we said, not a true option. The second option would be to undergo repeated shutdown, reopen cycles until there is an effective cure or a vaccine. This is not a particularly good option because it would be socio-economically devastating. So our third choice, that's the one that is favored by our governments, is to reopen the country, but make sure that as few as possible people are going to be infected. The reopening is done in a stepwise fashion under very close monitoring. Many restrictions will continue, as Anne has said. Physical distancing, basic hygiene measures, limitations on gatherings, face masks, at least on public transport. And in addition to that, we need to, in order for the R0 to stay low, we will need to test aggressively in order to identify those people who have been infected. We have to trace all their contacts and quarantine their contacts and test the contacts also. And everybody who tests it needs to be isolated so that they cannot transmit the virus to other people. And this approach works. The reason we know that this approach works is because South Korea has demonstrated it. As many of you will remember, they had one of the largest outbreaks in the world in January or February, and they were able to control it without ever performing a shutdown of their country. Other than that, we can only enter phase 2 when we have an infrastructure in place that will allow us to test and trace aggressively, and we will stay in that phase for a while. Phase 2 will only end once that there is a good medication or an effective vaccine around. And the test, trace, isolate idea depends on identifying people who carry the virus. The test you do for that is a direct test where you look for the RNA or for the protein of the virus. Antibody tests are not relevant to that. Antibody tests will not help you really to diagnose an acute infection. They show you if somebody has been infected with this virus in the past. So they allow us to see how many people in a population or in a country have already been infected and might now be immune to the virus. It may also, antibody titers may also give us an idea of whether we can give a green light to people so that they are able to return to work, because now they might be immune and now they are low risk. In this concept, immunity can be deduced from the presence of antibodies in the blood. So what kind of antibody tests exist? So there's two formats. There are rapid tests that work a little bit like a pregnancy test called lateral flow tests. They give you a yes or no answer, whether there's antibodies present or not. There's ELISA tests that are able to be scaled up so that you can perform high throughput screening of entire populations. And those ELISA tests are generally considered more accurate and provide a quantitative answer. So the question is, and this is a really important question, can we actually trust in antibody tests? So serological diagnostic tests, all of them, also for other infectious illnesses, are notorious for having issues. Most of these issues are usually related to the test's specificity. So will the test give us false positive results or not? In the case of SARS coronavirus 2, false positives may show up because somebody has had a previous infection with one of the harmless endemic coronaviruses that have been circulating in German and Swiss populations for years. So for an example, a good ELISA that is currently being used in German labs and that is commercially available has a specificity of 96%. That sounds pretty good. Only 4% of the positive results are false positives. But now, say 5 in 100 people have been sick. They have antibodies against SARS coronavirus. You test all 100 people. The 5 true positives test positive. Of the remaining 95, another 4, corresponding to the 4%, will also test false positive. So in the end, you get 9 total positives. Of the 9 total positives, only 5 or 55% are actually true positives. So that's not that great. But the other question is, does a truly positive antibody test actually mean that we are immune to SARS-CoV-2? And the answer to that question is, we do not know much about the immunity to SARS coronavirus 2, because there is a lack of studies. It's a new virus. So most experts will probably agree we can make two educated guesses, and those are guesses only. The first guess is SARS coronavirus 2 may lead to protection which lasts for months or maybe even for years in most or all people who have normal immune systems. And the reason we can make that guess is because we know about the immunity to the endemic, harmless human coronavirus that have been circulating for years. The second educated guess that we may allow ourselves to make is that antibodies against SARS coronavirus 2 may indicate protective immunity. So somebody who has antibodies, true antibodies against SARS coronavirus 2 has been infected in the past. Probably their immune system remembers that, and probably they are protected from infection in the future. So far, there is no scientific proof of that. So in summary, we can say that loosening our restrictions will require aggressive testing. Otherwise, there will be a resurgence of the epidemic. Good antibody tests can show us if we have been infected or not, but they're not easy to interpret. A positive antibody test does not guarantee that we are protected from infection, and life cannot return to normal until there is a therapy or a vaccine. And with that, I'm happy to take any questions too.
Thank you very much, Djin-Ye. That was a really very interesting presentation. I'd like to hand over to Jan now, who is moderating the question and answer session. And I just want to explain again, so you can either put your questions into the chat tool, or you can speak out now in the panel. So Jan, do you want to take over?
Thank you. I've got a couple of questions. Maybe first for Anne. There was a question concerning temperature. We heard some rumors some weeks ago that heat might be bad for the coronavirus, and that summer will save us, or that warmer countries have a better chance of containing the virus. What could you say regarding the heat and the virus? Is there a connection?
Yes, of course. We know that the virus dies if we we have temperatures of 70 degrees or higher. We don't get those outside, but we also know that the virus is destroyed by ultraviolet rays, but you need quite strong ultraviolet rays. What the person that's asking is referring to, that is generally like this: if I have a droplet, it means it's a virus with an outer layer of liquid. If it's warmer, this outer layer of liquid evaporates faster, and the droplet will sink to the bottom, to the floor. So you can't inhale it as easily. That is one reason why, for example, a lot of respiratory diseases like flu or common colds are more common when the weather is cold, okay? So there is hope that when it gets warmer, at least the transmission by air on the outside will not happen, but it's not warm enough in the rooms usually, unless you have 30 to 40 degrees, and in rooms you don't have any wind that will distribute the droplets. That's another factor. So I hope it will happen that the number of cases goes down when it's getting warm now. But we can't be sure of it, because it's a tricky virus, and it's very easily transmissible. So we'll have to see.
Thank you. Another question by Eckhart. Maybe you want to ask it yourself?
Yeah, thank you. Thank you very much to both speakers. It was a great presentation, both of you. I had a question regarding the contagious or the infection rate that you both mentioned. And in particular, I wanted to know do we have any idea of how much these infection rates depend on particular super spreading events, like, for instance, the ski resorts in Verbier and Ischgl, or the demonstration, the manifestation that happened in Madrid, etc.? So do we know how much the infection has actually spread throughout these events, and to what extent would it help if we simply limit these events in the future rather than kind of shutting down entire sectors of the economy?
I can say something, or can you say something?
Sure. Go ahead.
So what I think is, so one thing is the R0 of 2 to 3 is sort of an average estimate. In the New York City subway, you probably have an R of 6. At that super spreading event in Ischgl, I believe the R0 must have been 20, if not. It also depends on what people do. I believe in Ischgl, there was this thing where you kind of drink from, where everybody drinks from the same straw of that one drink from the infected person. And so this sort of super spreading events actually leads to an R that is significantly higher than the 2 to 3. And that is why there will probably always be some limitations on the size of different gatherings. And the other thing is that there are also most likely people who could be classified as super spreaders, because by now we know that the viral load plays a role in the infectivity of somebody. So people who have a high viral load, or if we are exposed to a high viral load, we're more likely to be infected. So somebody who, through no fault of their own, has, happens to produce a lot of virus, might be surrounded by an R0 that is also higher than 2 to 3.
Thank you.
And another question, maybe for Anne. We heard about some drugs, some medication being used, being tested, being talked about in the internet. How do you see it as something that we could expect, that there is a drug that helps us to treat the virus so that the mortality rates can go down?
Well, what I know that in the hospitals in my area, there are every patient with a severe COVID-19 disease is administered to drugs if he agrees to the administration. So in all hospitals worldwide, we're having trials with different medication, whether it's the famous anti-malaria medication or the anti-Ebola medication or some other drugs that are being tested in clinical settings. And I think we will have the first results in a couple of months, at least a tendency that we can see which drug does have a mitigation effect. We can't hope for a cure, I think, but whether there are drugs that mitigate the course of the disease. Outside of clinical trials, I refer to this panic, I mentioned in the beginning, okay? There are people that took this drug, especially hydrochloroquine, the one Trump promoted, and just as a prophylactic measure. That doesn't make sense now, and the risks of this drug are, as far as cardiac arrhythmias, are not neglectable. So if you want to do something like that, like you have to go into a high-risk setting, like, for example, now healthcare homes. I have a lot of healthcare home workers asking, can't I take something so I can prevent to infect me? The answer is no. I talked to the person individually, and in some cases I said, okay, if you insist to take something and if you're informed about the risks, there is a drug that is tested for prophylactic use. You can try that, because that is quite a low risk drug. But I don't want to make I don't want to make a recommendation over the internet. So if If you have fears or if you want to take something prophylactic, talk to your doctors. If you do get the disease, if you develop a severe case, you will get treated with medication. I think that's Europe-wide, not in the developing countries, but Europe-wide. There are clinical trials everywhere.
Thank you. Maybe another question also for Anne. Do we know which organs are attacked by the virus?
Well, COVID-19 is the abbreviation for coronavirus-induced lung disease. So the virus nests in the nose, in the throat, and goes down to the lung, where the lung develops a viral pneumonia that is quite characteristic and different to other pneumonias. You can almost define that a patient has COVID-19 after you do a computer tomography of the chest, because it's a pneumonia that looks different from other sorts of pneumonia. So the lung is affected, and nose and the throat. We have reports of some cases where the virus caused an encephalitis that means he passed the blood-liquor barrier and went into the brain and caused some damage there. What we don't know up to now, whether there are any long-term damages due to coronavirus as far as lung function is concerned. That is, that people have ongoing problems with the lungs. We know usually that people recover from severe corona, and even critically ill patients recover in 3 to 6 months. But since we don't have the virus very long, we can't say how long those effects last.
Can I ask a question
Yes.
in that context? Myself and Eckhart, for example, we are runners, and for us it's very important to have a good lung, and for me it would be a horror scenario not to be able to breathe. So for example, if you would have like the light version of corona, I think I read something that even that could cause some side effects, but I think we don't have enough history in order to judge that, right?
Well, we know that people have pneumonia but don't feel it. That is, we have people that are a little bit sick, yeah, like a common cold, have coughing, have a little bit of a fever, not very high temperatures, feeling a little bit weak. And if we do a computer tomography, we see a pneumonia. They recover, yeah, and those patients usually don't have an impaired lung function. Okay, so the mild cases I'm seeing that are not going to the hospitals are recovered after 4 weeks completely. Most of the young people are healthy again after 2 weeks. If you have the middle age group, they need a little bit longer, but after 4 weeks they are recovered and can do all their usual physical activity again. Okay, what we don't know yet is, but there's hope for optimism, because we have patients out of China that are completely recovered, yeah, even with patients that were in the ICU unit and even patients that were on ventilators. So there is hope that there is no lasting impairment of the lung function, but that the pneumonia will heal.
Thank you.
Thank you.
From Francisco, I've got a question concerning testing capacity. Can you say something about the testing capacity that is available right now and that will be available when we might relieve the lockdown?
I do not have a good answer to that, just because I don't know what Switzerland is doing. I think most people who are most politicians who are aiming for that capacity are certainly going to make sure that that there are enough reagents. That's what at Robert-Koch-Institute, that's one of the things that we've been looking into for several weeks already. Basically, we've been asking labs, how many tests are you doing? We're kind of trying to assess the tests are going to be needed, and we are in touch with, for example, with QIAGEN. This is one of the companies that make RNA extraction kits that you normally need in order to run your PCRs. We check with them how many kits they can produce per week. So it's something that people are planning for, but but it's certainly a problem. It's been a problem in China. That is why we know so much about the validity of CT scans in diagnostics, because sometimes they were just not able to run PCRs because there was one of the things that you need in the lab or in getting samples to the lab that was missing, or that because there was not enough. So it's a great question.
Yeah.
Thank you. Well, I can say for Switzerland that the number of available tests increased a lot. So they were able to broaden the scope of the tests. So personally, I've had some symptoms some weeks ago. They told me only tests for those with severe symptoms, and they changed it, and they were able to test me just a week ago. So we are seeing that more test kits are available. Maybe together with these test kits, a question from Daniel. How do you calculate the reproduction number since we only test some people and we don't really know about the numbers of people not showing symptoms or not being tested?
I think, yeah, so the R0s are usually gathered from, it's infectious diseases modelers who determine those, and they assume basically a certain percentage of people who are uninfected with error margins. As Anna said, I believe in general people think that about 20 to 30% are infected but not symptomatic, and then in a similar way you can estimate what portion of people is infected but not tested.
Thank you. Another question, there has been a recent Chinese study of testing people who have been tested positive with coronavirus, had been ill and have recovered, and in this study it showed that 30% had little or no antibodies. What does this mean for immunity, and how much validity would you see in this study?
Yeah, so this is really this is an excellent question also. So the study is, to my knowledge so far, it has not been peer reviewed, so it's available as a preprint online. And so, yeah, there's a few things that I'm not sure that they actually state in their preprint, like what the specificity was of the tests that they used. But the main test, the one that says 30% have low levels, is a very good test. It's a neutralization assay. But they had undetectable antibodies with that test in only 5% of people. The other 95% actually did have antibodies. However, as you say, about 30% of those people had low levels of antibodies. Interestingly, those 30% were young patients. And basically, I would not be concerned about these results, because 95% of people are capable, of people who recovered from the disease, are capable of making antibodies that are like measurable. The other 5% also recovered. I don't know why their antibody test is negative. It may be a false negative. They may also have antibodies. Because all of them recovered, I would assume that probably all of them had an immune response and may have one if they're re-exposed in the future. The main thing is immunity does not depend on antibodies alone. The antibody levels that we see, so far we don't know if they correlate with protection. So the people with low antibodies may still be able to, may have recovered the quickest. And because their immune system didn't have to fight for so long, they only have low antibodies. Those low antibodies may be very strong. Or technically the antibodies only signify that your body has seen the virus. So your immune response may depend on another part of the immune system, which is the T cell compartment. So it may be your T cells that actually helped you get cured or get healthy again. Does that answer the question?
Yes, thank you. Another question concerning the timing of antibody testing. When do you think they are ready, and when do you think it's the right time to do mass antibody testing?
I think it will still be a few weeks or rather months until we have reliable antibody tests. The best way to find out whether antibodies in the blood mean that you're protected is to monitor people who have antibodies in the blood and see if they're going to be reinfected, but you can't, you can't do volunteer studies like that because this is a BSL-3 virus. Yeah, I think tests with a specificity of 100% might already exist, but need to be validated. And yeah, so there are good tests around. And I think the validation studies, the point where institutions like NIH or Robert-Koch-Institute are going to say this is a antibody test that tells you that has 100% specificity. That point in time is soon, but I think it'll be a while until everybody is confidently going to say everyone who has these people are protected.
And these people could go, would not be under lockdown anymore. They could do whatever they want.
I mean, I think
we all wish.
It's going to be a gamble. I think it's going to be a gamble, but it may be a gamble that people are willing to take. We all wish it's going to be like that. I think at some point we're going to be like that. I mean, you can just assess the risk of people individually. A young, healthy person who has a positive antibody test, who would like to go back to school, who has no pre-existing conditions, they're probably protected, especially if they've also in the past had an illness that looked very clearly clinically, or maybe even with the PCR result, like on a lab level, like SARS coronavirus 2. So that person, I'm pretty sure they're going to be fine, The 65-year-old healthcare worker who would like to go back to the ICU, take care of COVID patients, and they don't remember a COVID, they don't remember having had COVID-19, but they may have been asymptomatic, and now their antibody test that they did with a test from the that they bought on the internet is positive. No. So you want to assess the risk, you want to see the clinical context. It's something that Anna will decide in her practice, I would say. I don't know if we can take all these test results and implement them on a policy level. A lot of people are going to weigh in on that.
Thank you. We are running a little bit out of time, so we can take 2 more questions. I've got one question from Fazad Kai. Maybe you would like to ask it yourself?
Yeah, thank you so much. Hello, everyone.
Hi.
And thank you so much for very good and so very good constructive things. That this is my question, that we just be close to the summertime, and the weather and the temperature is with more humidity, and we know that COVID-19 doesn't matter to just the cold temperature. I want to know that which process in summertime and which immunity factor have more important role in this period of time.
Okay, maybe I can start and you can add. I think that closed rooms are much more dangerous than the outside, generally, whether it's warm or whether it's cold. If you're on the outside, especially now that it's getting warm, you have that effect of drying out of the droplets, yeah? Plus you have a wind distribution of the aerosols. So as long as you keep your distance, 1 to 2 meters, I think you are much safer on the outside than you are in a room with other people, even if you keep your distance there. As far as immunity and summer, I would like to refer to Jean. Yeah.
Yeah. So to my knowledge, that there's no major differences between the way your immune system works in the winter or in the summer. So maybe sun has an influence on your vitamin D level, so maybe your immune system is a little more on top of things in the summer, but I don't have very solid data about that. So it's really the environmental things that actually we all hope are going to decrease the infection rate, the infectivity.
There is a much higher death rate for men than women. And do you have an explanation for that? For example, there has been a report that the virus could attack and reproduce in testicles. Could this be an explanation?
I think just in general, men are a little more prone to a lot of illnesses. That is why women in general have a longer life expectancy. And I haven't heard of the studies about the about what specifically may be responsible for that. The last thing I read was that men in China smoke more than women, but yeah, none of us probably thinks that men are at higher risk because they smoke a lot in Europe or in the States. So.
Wow. So we have 2 minutes left. Either we take one more question or we do 2 minutes longer. What is that?
Maybe there is a question from Paul considering a second wave. Maybe Paul, you could ask a question.
Sure. Okay. Thank you, Anne, and thank you, Jean. Very good insight from both of you. Considering the second wave currently happening in Asia with mostly the imported cases, does it mean that the population there, whether it's in China, Singapore, Hong Kong, Korea, or Japan, have not been sufficiently exposed, therefore have not developed sufficient antibodies? That's the reason why they are getting reinfected or infected because they were not infected at the initial start?
So in terms of the second, so that's a very good question. In terms of the second wave that is happening there, the reason you see it is because people aren't immune to it. So it's basically just because now the restrictions in China, for example, are being loosened, that results in more people being infected. I think even even in a place like New York City, we think that that is currently considered the epicenter of the pandemic of the world. I think we think maybe 15% of people maximum have had the infection. Some of them are still in the hospital and are immune. So in South Korea, certainly less than 1% of the total population is immune, because less than 1% have been infected because they've been so good about controlling the spread.
So that means that actually, in order to avoid such a second wave or third wave, meaning that people should wait longer before opening the borders, sort of, I mean, from a mathematical perspective?
Yes, if they're way ahead of everybody else, like, yes. Or you do it like New Zealand, you put everybody who comes into the country into quarantine for 2 weeks.
Okay.
I think that is.
Maybe I can add something. I'm living, as Jörn or Renate said, in the border region, France, Germany, yes. And the first cases we had here came out of France. Okay, we have workers crossing the borders every day, yeah, and they infected their co-workers, and from there we had what we call a community spreading, that not imported cases from the outside. And I think we're seeing the same now in China with the province next to Russia, bordering Russia. They have a spillover of cases too. So if you look at the absolute numbers, I said Johns Hopkins has the case rate at 2 million right now. Even if we consider the case rate is 10 times as high, that would be 20 million, but it's still a very small percentage of the world population. So even if in New York 100,000 people are infected, that's not even 1%, I think. Yeah, so that's we're going to see outbreaks in situations where there is an infected person, maybe asymptomatic, yeah, that has close contact to other persons. We're always going to see that. So that's why Djin and I said we have to live with social distancing for a while, right?
Actually, China has closed the borders, and even Chinese people that return need to quarantine themselves for 2 weeks before being admitted to normal social life there.
And then the second question I had relate to Sweden. Was actually the choice of Sweden, like not being confined, a good approach? Similar to probably UK wanted to actually follow Sweden. So the situation in UK unfortunately got worsened, and also in Sweden now, currently in Sweden, also the situation is also getting worse. I know some people want to try, but using humanity to try. I know that some doctors want to try more than others. I mean, it's a bet. Maybe it works or maybe it doesn't work. But
I think it's quite irresponsible because, like, now there is discussion about sending children back to school. We know that children don't get severely ill if they're healthy, if they don't have any heart diseases or anything, but they go home, they infect their parents. The parents go and infect their parents, and that is the risk population. So I think what we're seeing in the UK now is, beside the bad NHS, the cuts in the NHS, which took part in overwhelming the system. But I think finally what we're seeing in the UK now is a consequence of not social distancing early. I think Djin showed a graphic where she showed very well what happens if you start early with social distancing, and what happens if you start late. So I think Sweden is going a dangerous course. Yeah, it's the question what I want. I mean, I can say, okay, I don't care if the old people die in the old age homes, but what we are seeing right now practically is that the old age homes are shut off. There are no visitors, but the healthcare workers go in there.
Mm.
They often work unprotected, so they get infected somehow. Yeah, and like if they have children, they go to school, they are infected, don't have any symptoms, they infect the healthcare worker, they go in the old age home and take care of their patients, and they will die. That is my answer out of the clinical perspective.
Thank you.
Yeah. Djin-Ye, do you have something to add? I think your mom is also affected.
Yeah, I agree with Anne 100%. I don't quite understand the rationale behind that Swedish approach, because now I just recently read about they have outbreaks of this very infectious virus in a third of their nursing homes. So it's they keep doing what they're doing, and so as Anna said, it's quite impossible to reverse quarantine the vulnerable part of the population, you know, because you still need the invulnerable people to take care of them, and there's still going to be shortages of protective equipment.
Yeah, they were hoping that the herd contamination would be actually faster.
Yeah. 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 I mean, it's an experiment. We'll see.
Thanks so much, everybody. We could go on for, I think, well, some more minutes, but I'm afraid we are running out of time. Thanks very much for your presentations, Anna and Djin-Ye. Thank you so much for your questions. As I said before, we will have a summary of today, and we will try to answer those questions who haven't been addressed. Please join us next week, next Wednesday. We'll have a very exciting online talk. We will have the chance to listen to Eva Kaini. I don't know if you know her. She's from the European Parliament, and she will talk alongside a professor from the Geneva Graduate Institute, and they will talk about the brave new Corona world. So we are looking forward to seeing you next week, and yeah, stay healthy and have a good evening. Bye-bye.
Maybe you can add a little bit. In 2 weeks' time, we will also discuss a COVID-19 specific issue. We will discuss privacy aspects of the tracing app.
Yeah, exactly. Thank you very much for adding that. Yeah. Have a good evening, everybody.